Thank you, Oliver, and thank you for the invitation to speak. I think just before I start, I might just shamefully go off topic with a plug for a study that we're about to start. There's been a lot of discussion around anti-inflammatory relievers, and I know in Andy Turnbull's talk, he kind of highlighted some of the evidence gaps, and I'm very pleased to say we're about to start a study of anti-inflammatory relievers in children aged 6 to 11, and it was mentioned by Sarah Sleet in her talk as well. So it's funded by NIHR, and Asthma and Lung UK are partners in that research, and hopefully the website will be going live in a couple of weeks, and we'll have a number of study centres around the UK, but parents can also register their interest. So even if they're not being seen in a study centre, they can still register their interest and be included in the study. So I'd hopefully once we get started, I'll disseminate that and we can help to plug some of those evidence gaps. However, moving on to the topic in hand, who isn't being referred to a severe asthma service? So we can go to my next slide. So these are my disclosures, and on the next slide. So what I'm going to do is think first about who should be referred, and Andy's already showed the referral kind of guidance that we have, and I'll go through that. Then think about, are the right children being referred? What's the purpose of being referred? What does a severe asthma service offer? And then finally look at referral data from CPRD, which is a primary care database, and look at who is and isn't being referred. So we can go to my next slide. So this is from the National Bundle, and this shows the kind of the flow of children through various asthma services and how they might kind of end up in tertiary care or a severe asthma service. And we see it's kind of down at the bottom. The reality is there's be more complexity to this, and it's not necessarily just a kind of a stepwise kind of entry into into tertiary care, and that's what we've tried to reflect in our referral kind of guidance. So if we go to the next slide, so we developed this within the London region, and I'm thinking about which children should be referred, and this is now included in the National Bundle resource pack as well. This is quite a busy slide or a busy figure, and I'm going to just break it down and go through each part in turn. We are revising it at the moment, so if anyone's got any comments or any suggestions, that would be welcome. And I think probably just simplifying it a little bit, as I say, it's quite a complex flow at the moment. So if we go to the next slide, so what do we mean about problematic severe asthma? So severe asthma services look at all children with the children want referred are those with problematic severe asthma. And kind of broadly speaking, this would be poor control at GINA step 3, or children at step 4 who have already made it to step 4 or 5 to maintain their control. So they're on high dose treatment. And the indicators of poor asthma control are asthma attacks, hospital admissions or emergency department attendances, 6 or more SABA relievers per year. And again, you know, that's the Sabina Junior study has highlighted that 3 or more is associated with increased risk, so perhaps we ought to lower that. And an asthma control test or childhood asthma control test score reflecting suboptimal control. And if we go to the next slide, so this is the current GINA figure, and I've included this just to highlight when we're talking about steps 3, 4 and 5 what we're talking about. So we can see at step 3 is low dose ICS LABA or medium dose ICS. And this is also where MART comes in for children. And then at step 4, you can see the very first thing it says is refer for expert advice. So children kind of uncontrolled at step 3 who are moving up to step 4 should be referred. And then additionally in step 5, it's kind of looking at that phenotypic assessment so that we can assess eligibility for biologics. And just if we go on to the next slide. So Andy's kind of touched on this already, but thinking about what are those doses that we're talking about. And step 3 is low dose ICS LABA, medium dose ICS, or very low dose ICS for Motorol MART. And we can see those doses, the dose boundaries are different for younger children and older children, but again, it's worth bearing these in mind. And by the time we're getting to step 4, the doses are kind of increasing, but particularly for younger children, they are relatively low doses. And I think, and actually the message is, we shouldn't be just continually escalating inhaled corticosteroid treatment. We should be thinking about onward referral, or thinking about those reasons why the treatment isn't working. And Sarah's been through a number of those reasons already. And these are all kind of daily doses. So if we go to the next slide. So the first part of that flow diagram is to say, is there evidence, is there objective evidence of asthma in terms of spirometry, bronchodilator reversibility, elevated exhaled nitric oxide, or peak flow variability? And this was based on the previous NICE guideline. And as we've already heard, that's been updated, and the draft BTS NICE guideline is out. It has been out for consultation, so we'll wait to see what the final guidance will be. And then if there isn't objective evidence of asthma, then considering alternative diagnosis and referral for additional testing. And the sorts of additional testing that are available within a severe asthma service include not only those tests, but tests of airway hyperresponsiveness, so methacholine or histamine challenges, other lung function tests, so such as the forced oscillation technique, measuring using impulse oscillometry, or multiple breath washout to measure lung clearance index. And these tests have the advantage that they don't require forced respiratory manoeuvres. They're done during normal tidal breathing, and therefore they're possible that younger children can do them, or children who can't do spirometry can do these sorts of tests, and they can be very useful. Induced sputum we mostly use from a research perspective, looking at blood eosinophils as well, cardiopulmonary exercise tests, CT of the chest, bronchoscopy, and even continuous laryngoscopy during exercise, whereby we put a scope down, secure it just above the vocal cords, and see actually what's happening to the larynx during exercise. So these become kind of more and more specialised tests, but this is what should be available in a severe asthma service to help kind of assess whether this is asthma, whether all the symptoms are because of asthma, or if there are alternative diagnoses. What we're finding actually is that in terms of children who are being referred, we're seeing lots of referrals coming through because of the lack of availability of objective tests in primary and even in secondary care. And I'm a huge supporter of objective testing for asthma. I think it's right that we should be testing children. We should be trying, if we can, to confirm the diagnosis. Andy's already highlighted some of the issues with that in terms of needing repeat testing or variability because of variability in airflow obstruction. However, we don't have the capacity within secondary and tertiary care to be doing all that testing, and I think it's really important that we continue to advocate for children and ensure that those diagnostic hubs or access to diagnostics is available for all children in primary care. Because at the moment, I would say, as I say, I'm seeing referrals coming through to my severe asthma clinic, just purely, a child with a cough, but can we do some diagnostic testing? And coming through, that's the majority of referrals I'm seeing coming through to the clinic that I do in secondary care, which is kind of mostly referrals from primary care. And as I say, we don't have the capacity for that, and the more of our capacity that's being taken up with testing then kind of reduces our ability to kind of see children with poor asthma control who we should be assessing. So I don't want to send a message that we shouldn't be doing this testing. We absolutely should, but we need to have the right facilities for children in the community to do that. So if we go on to the next slide. So this is a really interesting piece of work that was done in Leicester. They set up a diagnostic hub, and that hub was intended for rapid review of children who'd had an asthma attack, and also for children in primary care who had poor asthma control. And they carried out diagnostics at that time, so looking at spirometry and exhaled nitric oxide. And actually they confirmed the diagnosis of asthma in just over a quarter, and those who were referred from primary care with poor control, the rate of diagnosis was even higher. And this again highlights that we're more likely to have positive tests when a child is symptomatic. And I think it was a kind of a really good model that fulfilled both the kind of post-attack review, but also was opportunistic in carrying out that diagnostic testing. So these were children already on treatment. As I say, it was that will be published in the near future in archives, so look out for that. Next slide, please. So the next part, so we've the first part of our referral figure was looking at confirming the diagnosis. And then the next part is has management been optimised? And management can be optimised in any care setting. So looking at inhaler technique, adherence check, and Sarah highlighted, looking at things like the prescription uptake, reduction in allergen exposure, treatment of comorbidities such as hay fever, and thinking about psychosocial issues. If it has been optimised and control is still poor, then onward referral should be made. If actually with optimisation and management control improves, then it's important to step the child down to the lowest dose of inhaled corticosteroids that can maintain that control. And if that's, if they're needing those higher steps, then they should be referred on. So the next slide, please. So other reasons for referral are any child who's had a PICU admission for asthma should be referred to a severe asthma service, and almost all PICUs are co-located with respiratory teams, and even if they're not co-located with a severe asthma service, there should be a mechanism for an onward referral to that service. Often children will be admitted to PICU out of area, and so actually finding the right service to refer to is really important. Other specialist input that can be offered through a severe asthma service and as a reason for admission includes complex psychosocial issues, including safeguarding, and I would say the majority of our time is spent on kind of trying to unpick what's going on with those children. Enrolment in a clinical trial. At the moment, we have a study running of a head-to-head between omalizumab and mepolizumab, and so it's important that we the importance of getting kind of clinical trial data from children, not just extrapolating from adults, is really key. So we sometimes get children referred for that reason, or input from other members of the team, so particularly specialist physiotherapy input. And again, that's such a precious resource, and there's very few physiotherapists with working within asthma, so often we get referrals just for that. And then there's a box that then says any child with asthma that causes concern can be referred, even if they do not fulfill any of the criteria that we put in the flow chart. And my kind of take-home message would be, if in doubt, refer. So if we just go on to the next slide. So, and I know a number of talks have gone through this, but I think it's really important to kind of keep on going over the basics and highlighting the reasons for poor control and this can be done at any level of care. And as we get to severe asthma services, we have access to a wider team and a wider range of ways that we can carry out these assessments. So in terms of adherence, if we just click on, I say inhaler check is really important. We also use electronic monitoring devices so that we can get a really clear idea of the amount of treatment a child is taking, and we can interpret their control in the context of that adherence. And then our intervention then can focus on actually will improving adherence help to improve their asthma control. So we find electronic monitors really, really helpful in the assessment. Assessing allergens, carrying out allergy testing, working with allergy clinics so that if appropriate, children can have immunotherapy. And of course, in order to be eligible for immunotherapy, you have to have well-controlled asthma. So that's, it's really important that we help to achieve that. If we click on thinking about environmental exposures, and again, that's been a theme throughout the day, the importance of the home environment, indoor air, as well as outdoor air quality. And we're very lucky in that our nurses carry out home visits, so we can see firsthand the child's living conditions and try and give support for improved housing and rehousing, as well as advice around smoking or vaping cessation. And the next. slide. And then, as I mentioned before, psychosocial issues are probably the biggest bulk of our work. And again, having access to specialist psychologists who really understand those kind of interactions between asthma and stress and anxiety and all those other issues is really important. And then finally, thinking about asthma mimics, or if we can just click on, that's it, and one more time. Thank you. So thinking about asthma, comorbidities or coexisting conditions or things that mimic asthma, so particularly rhinitis, hay fever and dysfunctional breathing. And as I say, we're very lucky to have physiotherapy expertise to help with breathing retraining. So if we go on to the next slide. So this is in the national bundle and kind of really summarises the outcomes from a severe asthma assessment. I would say there's a mistake on this this figure, that when it was transcribed from the original publication, and I shall point it out to you. So essentially you have an MDT assessment and intervention, optimised management, confirmed diagnosis. If there's ongoing poor control, despite that, then these are the children who we're assessing for eligibility for a biologic. And sometimes we might not find any factors, or even with modifying those factors, we still see ongoing poor control. And they're the children with severe asthma. And for others, we know that that those factors are intractable. So particularly some of the psychosocial factors, or, despite all our best efforts, we can't improve adherence, but those children remain at risk and they would be assessed as well. For those who want to kind of go through this process, and that's around 85% of the children that we see, they have improved control and don't need to be assessed for a biologic. So that's the box on the left with difficult to treat asthma. And actually what it should say is then you step down to the lowest dose that will maintain their control, rather than assess that these children don't need a biologic. And we've already talked about those who don't have asthma, and then going on to assess for other conditions. So if we go on to the next slide. So this is a very busy slide. I won't go through it all, but it essentially kind of defines which kind of patient groups are seen in different care settings, when to consider onward referral, and then once they've been referred, what should be available. So if we go on to the next slide. So this summarises the children who should be referred to the severe asthma service, so the patient groups, just to go through them again: any children referred, any children who've had a PICU admission, children kind of from step 3 who are uncontrolled, and those once you've reached step 4 and 5, they should certainly be seen within a severe asthma service if there's diagnostic uncertainty or enrolment in a clinical trial. And then the next box really just goes through all the interventions or the assessments that should be carried out in it, or that should be available in a severe asthma service. Again, reviewing the diagnosis, access to many other diagnostic tests, monitoring side effects of treatment, so things like short synaptin tests, DEXA scans, biomarker measurements, adherence checks, and ideally, as I say, electronic monitoring is the best way of doing that. Unfortunately, it's not funded, so it's quite difficult for all services to offer that. Investigation and treatment of comorbidities, and then initiation of biologics. And then there should be a wide MDT with children's asthma nurse specialists, physiotherapists, psychology, specialist pharmacists, and Sarah's highlighted all the fantastic, the fantastic things that pharmacists can do. And as I say, we're very lucky to have pharmacy input in our MDT, the physiologists, and then access to allied services such as dietetics, ENT, and allergy. And we've really gone through those who should be referred. So if we go on to the next slide. So that's kind of giving you a background as to who should be referred. So who actually is being referred. So this is some data that we looked at using CPRD. And it's got pretty good coverage for primary care. And we looked at children 6 to 17 years of age, and we defined poor control for the purposes of this study is 6 or more SABA inhalers in a year, 2 or more courses of oral corticosteroids, an ACT or CACT of less than 20, or a hospital admission or an ED attendance due to asthma. And we looked at coding within primary care. So we just, next please. So this is the study population, and we divided into 6 to 11 years and 12 to 17 years, and over 180,000 children were included. So if we go on to the next slide. So this is looking at asthma control, and we can see that overall there were biggest kind of proportion of children with poor control were at steps 0 to 3, and relatively smaller numbers prescribed steps 4 and 5, although still a number of those had poor control, and that was particularly the case in 12 and above. So overall, looking at the whole study population, 17.6% had poor control. Poor control was higher in boys than girls, and there was a higher prevalence of poorly controlled asthma among the most deprived, again echoing what we've heard so many times today. 4.2% of children were at GINA steps 4 and 5, of whom 40% had poor control, and this kind of fits with the figure of around 2.5% that we say have severe asthma. So if we go to the next slide. So how many of those children were being referred? Well, only 6.2% of children at steps 4 and 5 with poor control were coded as having a referral, and 1.6% of children at GINA 1 to 3. So really, really small amounts. And the factors most strongly associated with referral were courses of oral corticosteroids. And that probably reflects the fact actually that asthma control test, or CACT, isn't often recorded actually in primary care records. So if we go on to the next slide, you can say, well, that might just be a coding issue. Perhaps more children are being referred, or they might have been referred via other pathways, for example, if they'd had an acute admission, and therefore that is not showing up on the database. So let's just think about the numbers. So 9 million school-aged children in England. So I just looked at English data for this. 1 in 11 have asthma. So if we go to the next, that gives us a total of 810 children with asthma in England. If we just click on through, so as I say, from those data, 4.2% at GINA 4 and 5. So next, that equals 34,000 children. And next, 14.5% at GINA 1 to 3 and poor control. Next, that's 117,000 children. Well, we're certainly not seeing 34,000 children in our severe asthma services. And if we go on to the next slide, I've broken it down for London. I've done a similar process for London, and there would be around 5,000 children in London reflecting those CPRD figures. We did some recent work in London where we collected data from each of the severe asthma centres, and if we just click on, we can see that there were, on the estimates of the severe asthma centre, 231 referrals in the past year, and currently there are 71 children on biologics. So you can see there's a huge disconnect between who should be referred and who would potentially be eligible for biologics. So there's probably a lot of children, well, we know there are a lot of children out there who would benefit from additional assessment to improve their control and would benefit from a biologic, and we're really only seeing the tip of the iceberg. So if we go on to the next slide. So we also looked at factors which increase the likelihood of being referred, so being younger. And interestingly, we saw actually poor control was more frequently seen in teenagers, and yes, it was younger children that were more likely to be referred, being female, and interestingly, actually living in a more deprived area, and then the concomitant presence of food allergy. So if we go on to the next slide. So when do clinicians refer? So this was some work that was published by Will Carroll a couple of years ago, and I think the initial questionnaire was actually carried out by Novartis, who are obviously very keen that people are referred and children are referred and more start on biologics. But nonetheless, the survey was how many courses of steroids, how many A&E attendances, how many days off school on average would trigger a referral. And as we see, so referral from primary care to secondary care, a median of 3 attacks or 3 courses of oral steroids. And then onward referral from kind of secondary care to tertiary care, so among general paediatricians, a median of 4 attacks and 30 days off school, so a huge amount of time off school before that would then kind of trigger onward referral. And interestingly, in each of the categories, there were quite a high proportion actually who didn't have who replied didn't know, they didn't really have a sense of when they would refer. So kind of much higher thresholds than the ones I've suggested in the referral kind of guidance. So if we go on to the next slide. So in summary, we can see from primary care records, poor asthma control among children is very common, and yet referral rates to specialist services are extremely low. We have seen an increase in referrals for diagnostics, and as I say, I'm pleased that more that more objective tests are being carried out in children or being requested for children, but we need access to them through community and primary care rather than through kind of hospital-based care. We need better tools for risk stratification, identification of children who should be referred, and they should be kind of flagging up on their records that they've kind of reached threshold for referral. And then once referred, it's really important that children have access to an equitable service and access to biologics. So next slide, that is just my acknowledgement. So thanks to all the fantastic team at the Royal Brompton, and also stay to NIHR who fund the research, and Asthma and Lung UK who've been hugely supportive of my career and research. So thank you.